Yeah, so I won't talk much about this, but I do think that chronic pain patients are often a stigmatized population. Some because there's a lot of suspicion about people using opioids or other medications, concerns about folks hustling for disability, even we'll talk about this when we get to family members, even concern about, well, maybe this guy's just loafing, you know, just using this to get out of responsibility. That's an issue. I'm going to move on. This is one interesting point that most people don't know about, though, that in many cases there's been substantial basic science research going on, particularly in the last 10, 20 years, that actually in the last 10 years has been responsible for some new medications, some really valuable new therapies out there. Our nervous system responds to an ongoing pain input by sensitizing itself, which is a new, that's bad. So that if somebody has pain from the periphery, from the outside of one's body, talking to the spinal cord, over time the spinal cord neurons carrying that signal shift what they're doing so that they intensify the pain experience. There are actually several different mechanisms going on. Over time, sometimes the same nerve fiber in the spinal cord will now send a pain signal in response to stimulation from an even bigger area. So if the pain started here, after a year, now if I touch this part of my hand, I have pain, the experience of pain. Anyway, the point is that our nervous system shifts in ways that sometimes causes us to have even more pain over time. The good news about that is folks have learned a lot about the physiologic mechanisms of that sensitivity, and there are medications out now that get right at that and that are really helping for neuropathic pain in general and for more other kinds of pain that may trigger this sensitization. That's okay. Well, let me go back to this because it's kind of fun. The other main theme that I want you to get is that pain, from a scholarly perspective, it's fascinating, and if you're living with it, it's deviling, that it's a subjective experience, meaning nobody can stick a meter on your head and find out really how much pain does he have. You know, the best way we have of assessing someone's pain is asking them. And things like, you know, give me a rating on a 0 to 10 scale, 0 meaning no pain, 10 meaning the worst pain you could experience. But everybody knows, you know, that's imperfect. My 5 isn't the same as your 5. And we, you know, of course, it's my job and the job of clinicians to figure out ways of assessing that and making it more precise and more objective, and we do. But again, because it's such a complex experience, nobody can really know exactly what another person's pain experience is. Yes, sir?
My experiences at hospitals, they've asked me to rate it on a scale of 1 to 10.
Yeah.
At one point I said 10 and they wrote me a prescription for Lortab. Does that mean that if you say 5, there's a cutoff, like, or is it like, I mean, I'm not going to use this to try and get prescription drugs, this information, but like, is there a number that you can say that's like, will get you opioids, and like a number that's below that?
That's a great question. Shouldn't be. And in our part of the healthcare system, our policy says that. No, I'm sorry. Let me go back a step. That 0 to 10 rating should be regarded as a screening. You know, if you and the way I would like it to be, the way our policy reads, is if someone coming to a first appointment with a primary care provider, and they, in our hospital, that 0 to 10 rating is the 5th vital sign, meaning when we get blood pressure, heart rate, temperature, respiration, we ask a 0 to 10 rating. If you give any number other than 0, that means that the provider has to ask more. And the first question is, do you want us to do more about this? And you can say, no, it's fine. But even there are some people for whom a 1 or a 2 is a terrible problem. I had a guy, his pain never got above a 4. But if he couldn't have time when he was pain-free, it made him nuts. And so when he couldn't have some pain-free days, he would come in. And if we could put that back in place, he'd be fine. But you know, a 2 or a 3 was hell for him. And I don't really think it was much pain. But anyway, Some places will say, well, if the pain gets above a 3, then we'll assess it further. Or in an inpatient unit, we have to medicate any pain that's above, that's a 4, and a pain of 7 or above requires a response within X amount of time. Because it's so subjective, that's hard to do. I feel most comfortable with, like, absolutely not. The number shouldn't dictate a therapy. In fact, nobody should be giving out a medication unless they know what it is they're treating. And furthermore, assess contraindications, reasons why maybe you shouldn't have that medication. Have you had an allergy to that class of medications? Certainly in our VA system, we have a computerized medical record. It's striking to see how many people get prescriptions for opiate medications who have an opioid abuse, substance abuse history. So anyway, no, I would hope that when you present to the ER, they find out what's going on, is this an appropriate therapy, and then, right, if that's something that would likely help you to be more comfortable while they craft a more elaborate plan, yes, but not at all tied to the number.
So it's a sliding scale.
Well, it should be the beginning. If you say it's a 10, they say, whoa, what's going on? We better. Yeah. And if you say, if you tell me it's a 2 or a 3, I'm going to ask, well, how problematic is that for you? One of the questions that I'll ask is, for a chronic pain, what number does your pain have to get down to so that you feel like you can function day to day? Even that's huge. For some people, I have folks whose pain never gets below a 6 or a 7. I mean, really severe pain. And they'll say, oh God, you get me a 5 and I'm happy. I can do everything I need to do. I know other folks for whom, right, 5 is the most. And so, yeah, it's just a starting point. Yeah, so, and thank you. That gets right at what we're talking about. There's so much to understand to really get somebody's pain experience. And that's definitely, trying to communicate to providers what's going on, how do we get on the same page. Even, people might use very different terms. There's some cultures. There's not enough time to go into this story, but a colleague of mine did a wonderful thing. A Chinese doctor who works at our hospital went back to China following the Sichuan earthquakes, and she reasoned that they would not probably respond at all to the same sorts of interventions that Americans would, and we're not going to comfortably accept some of the same therapies. And anyway, people just experience their pain, describe their pain very differently, and you have to take that into account. So it's a big deal, and that's one of the problems for healthcare providers in managing chronic pain. Chronic pain should be managed like any other chronic illness. It requires a relationship, between the patient and the provider, so that you really understand how it affects that person. For some people, well, the pain is fine. It's just if I can't play with my kids that it's a problem. You fix that problem, and I'm good to go. For other people, it's I can't concentrate. Everybody has different goals. Anyway, so pain is a subjective experience. It's a big problem. It's invisible. Nobody can see your pain. But it'll take me a minute to move up, to the bit about relationships. But let's jump right to that, because that's, yeah. Don't know if you can read this. This, by the way, a couple of these slides I closely paraphrase from a self-help book by Dennis Turk and I think it's Eric Winter that I hadn't used that much in the past and just really took a good look at it. And it's pretty good. I like it a lot.
And it's on the back of the...
yes, it's on the reference list you have there. So, yeah, very typically, and this is certainly true, when you have chronic pain, often people around you may assume your pain to be temporary, to be easily treated, and likely to resolve on its own. They're thinking of that acute pain model. Somebody should fix this. And some things that we'll add on that in a minute. They may believe that the person in pain is fabricating. Well, how do I know? How do I know you're really hurt? Because I can't see it. That they're not following doctor's orders, or one out here is, well, did you get the right doctor? I heard, my friend next door went to see a doctor who helped him a lot. Why aren't you seeing that doctor? You must be doing something wrong here. May just be seeking attention. Oh, he's just looking for people to dote on his needs and avoiding responsibility. And of course, we're all possibly able to do that, but these are the direct consequences of other people not being able to see your pain. Let's